For evaluation of stable angina or any coronary artery disease, first thing to address is patient's clinical findings. In this case, if patient comes in with classic anginal pain or clinical features like substernal tightening, squeezing chest pain lasting less than 10 to 15 minutes and is relieved by rest or nitroglycerin, then we may suspect that the patient might have coronary artery disease. Afterwards, we can order a resting ECG. Usually in patients with stable angina, resting ECG is normal, but if it comes out abnormal, then unstable angina or MI can be considered. Further on, if resting ECG is normal, then patient can be advised to undergo stress testing. For example, stress ECG or stress echocardiography. On stress ECG, we can see ST segment depression due to subendocardial ischemia. Here on lead 2 and lead 3, we can see ST segment depression, which is due to subendocardial ischemia. And stress echocardiogram is done to see any wall motion abnormality and is common in patients with coronary artery disease. This is a parasternal long axis view. Here we can see mid-anterior septal wall, basal anterior septal wall, along with mid-posterior and basal posterior segments. And in this echo, we will see mid-anterior septal hypokinesia. So here we can see apical septum, apical lateral wall, mid-septum and mid-lateral wall, plus basal septum and basal lateral wall. So on this echo, we can see hypokinesia or akinesia of apical septal segments as well as lateral segments also. Wall motion abnormalities can also be seen in patients undergoing pharmacologic stress testing, that is via IV adenosine, dipyridamole or dobutamine. This pharmacologic stress test is done in patients who cannot tolerate physical exertion on chest. Finally, the definitive diagnostic test or the test of choice for coronary artery disease is coronary catheterization and coronary angiography. By angiography, we can see occluded vessels with the help of injected contrast. Catheterization and angiography are also recommended when any of the above mentioned tests come out positive. Then the patient is directly diverted to angiography and catheterization. If on angiography we see left main artery occlusion or 3-vessel disease or 2-vessel disease with history of recurrent diabetes mellitus, then the diagnostic angiography should be continued with therapeutic revascularization surgery, that is in severe cases bypass grafting is done.